Uh, can we start?
Yes, sir.
Just asking Srinath.
It's live now, so you can start.
Okay. Okay, Kirtana, go ahead.
Yeah. Good morning, everyone. First, I would like to thank Srinivasa and Gansham sir for giving me this opportunity to talk in Higgs. So today I'll be discussing about management of corrosive ingestion. So corrosive ingestion is a rare but a devastating medical condition that occurs. And it's relatively rare in developed countries due to the enforcement of strict regulatory measures in terms of production and sale. But it's common in developing nations like India because of the easy availability, most commonly as our household cleaning agents, and a loose regulatory control in terms of production and sale. So, corrosives cause a severe injury to the gastrointestinal tract, predominantly the upper gastrointestinal tract, in both acute and chronic phases. But it could also result in facial burns, skin burns, and things. And emergency, usually the management of strictures occurs in tertiary referral centers, but the emergency management usually occurs in the peripheral centers, hence emphasizing the importance of the early appropriate care, which is important in limiting the injury and also improving the long-term outcomes. So, an improper initial management could result in acute and long-term complication. Hence, it requires a thorough understanding of the epidemiology, the pathophysiology, the acute management, long-term sequelae, and prevention of corrosive ingestion. So the term corrosion, it comes from a Latin word which means to gnaw or to eat away. So it reflects the tissue injury or the destruction that occurs because of the corrosive ingestion. It could be either an acid ingestion or an alkali. Acid ingestion, most commonly sulfuric acid, hydrochloric acid, which are available as toilet cleaners, and aquaregia, which is the goldsmith solvent. An alkali injury, second, it is ingestion of sodium hydroxide and sodium hypochlorite available as bleach. And in Western countries, it's most probably secondary to an alkali ingestion. And in developing countries, because of the easy availability and cheaper form of acid available for the household cleaning purposes, it's more common in developing countries like India. Then ingestion could be accidental or a suicidal intent. So most commonly in children, it's secondary to an accidental ingestion, and it results in a rapid intake and more predominantly gastric injuries. But in adults, it's secondary to a suicidal intent and consumption of large quantities, and it could result in severe oral, pharyngeal, esophageal, and also gastric injuries. Next, so acids are the ones that have a pH of less than 2, and alkalis with a pH of more than 12. And the severity of these injuries depend on something called the titratable acid or alkaline reserve, which is what quantifies the amount of the acid or the base ion that the body's physiological response donates to the injured tissues to return them to the physiological pH. But the titratable acid or the alkaline reserve is not known in clinical settings. Hence, we use parameters like the pH of the solution, the concentration, the physical form, whether a liquid or a solid, or the quantity ingested, and the duration of the mucosal contact to assess the severity of the injury. And pathophysiology, I'll be discussing under these headings. So it could be a solid injury, solid causing the injury, predominantly the oropharynx causes the local injury. And the liquids, they flow rapidly into the esophagus and the stomach and causes predominantly an esophageal and a gastric injury. The vapors, ammonium, causes severe airway burns. And small bowel injuries are rare but could occur if large ingestions are taken or in cases of patients who have a post-gastric surgery. So, how do they cause injury to the esophagus and the stomach? So, acids mainly cause denaturation of the proteins, which causes the coagulative necrosis, and that causes a coagulum or a eschar formation, and it further limits the deeper penetration of the acids. Traditionally, the stomach is more affected in acid ingestions than the esophagus, because it's less adherent compared to the alkalis. And as soon as it reaches the stomach, induces a pylospasm and increases the gastric emptying time, increased gastric contact time. So causes severe gastric injuries. On the contrary, the alkalis cause a liquefactive necrosis, secondary to a saponification of the fats and protein dissolutions. Hence, they cause deep transmural injuries and they have a high chance of formation of strictures on the long term. So, it commonly affects the esophagus because it adheres predominantly to the esophageal mucosa, causing esophageal injury, transmural injury, and even perforations. But exception to this is strong acids or bases, they could cause full thickness necrosis. Uh, corrosive injuries could occur in 3 phases. First, acute necrotic phase, where they occur 0 to 72 hours with cell necrosis, thrombosis, and mucosal damage. The second phase occurs over 3 to 12 days, where they predominantly have mucosal sloughing, fibroblast proliferation, and a high risk of perforation. And hence, it's ideal to avoid endoscopy at this time. And phase 3 is the phase of healing and cicatrization, occurs over a few months, where scar formation and stricture development occur. Next, what about the clinical outcomes? So mild injuries usually heal without any sequelae. Moderate injuries result in stricture formation and complications of stricture occurrence and management of strictures. And severe injury could either be acute or chronic. Acute in terms of esophageal or gastric perforations leading to mediastinitis and peritonitis, and chronic complications in terms of stricture formation. And severe injuries could cause systemic toxicity like life-threatening dyselectrolytemias. For example, in hydrofluoric acid consumption, the fluoride ion dissociates and it binds to the cations like calcium and magnesium and could result in life-threatening dyselectrolytemias. So a gist of what we went through in the last few slides. So it could either be an acid or an alkali ingestion. Acids predominantly causing coagulative necrosis and alkalis causing a liquefactive necrosis, and could be either solid or liquid form and occurs in 3 phases as discussed. So clinical features. Clinical features of post-corrosive ingestion could be immediate, delayed, or remote. So they could be mild and they can present with just mild throat pain or erythematous oral mucosa edema, or moderate to severe in case of esophageal involvement. They could present with odonophagia, dysphagia, and if they have laryngeal and upper airway injury, they could have hoarseness and stridor, and they could also imply an airway compromise and emphasize the importance of early airway management in these patients. And if they have a gastric involvement, they could have epigastric pain, hematemesis, and severe injuries could present with respiratory distress and inability to manage secretions. And in case of perforation of the esophagus, stomach, or even bowel, could present as mediastinitis and peritonitis. So the complications could be either short-term or long-term. Short-term in terms of immediate complications like perforations, peritonitis, mediastinitis, and even death. Long-term complications secondary to the esophageal strictures, predominantly secondary to the alkali ingestions. And gastric outlet obstruction takes about 5 to 6 weeks to present. And there is almost around 1,000 to 3,000 times high risk of malignant transformation secondary to an esophageal caustic injury. And they predispose to squamous cell carcinoma of the esophagus and could take around 20 to 40 years to develop post-ingestion. So management, I would like to talk under these headings, that is initial resuscitation, evaluation of the grade of injury to help us guide further management, and indications of emergency surgery, long-term sequelae, prevention of stricture formation, and prevention of corrosive ingestion. So initial resuscitation, I think initial resuscitation and evaluation should go hand in hand. So the main thing should be emphasized on focusing on the intent, the extent of the injury, the substance that has been ingested, the concentration, the dose, and the duration of the contact, and also history about co-ingestions should be sort of. And airway breathing circulation, as any other resuscitation, takes the first priority. And patients who have signs of airway compromise, like poor cough, stridor, or even hoarseness of voice, should get a airway secured as soon as possible. And these patients have a high risk of a difficult airway, so you have to follow a difficult airway algorithm while securing airway in these patients. And if the patients have laryngeal injury, tracheostomy might also be required. But the standard toxicological principles of decontamination, like gastric lavage and activated charcoal, does not hold good in corrosive ingestions, because they could further aggravate the injury secondary to the GI decontamination. And also charcoal, the particles could obscure your endoscopic visualization. So hence, these are not preferred in corrosive injury. And strict monitoring of hemodynamics and dyselectrolytemias in these patients, because they have a rapid fluid shifts and third spacing and decreased intake. So hence, monitoring of our hemodynamics, and a good dose of administration of parenteral analgesics to decrease the pain. So what are the things to be avoided? They mentioned that avoid supine position. The reason for this is patients in supine position could have further aggravation of the esophageal injury, secondary to the reflux from the gastric compartment. And gastric lavage induced emesis is avoided, and a rice tube insertion. So early insertion of a rice tube is contraindicated in these patients, and unless required could be placed under endoscopic guidance, because there's a high risk of esophageal perforation that could occur. And neutralization with acid or alkali is avoided and contraindicated, because any reaction causes an exothermic reaction and heat production and further aggravation of the injury. And at home, like, does immediate dilution with milk or water post ingestion, does it help? They have mentioned that there's a minimal benefit with this. So other supportive measures like proton pump inhibitors, does it really help? There is limited evidence to support this use, but could be used to prevent reflux-related injury. Then corticosteroids. Corticosteroids do not prevent stricture formation, but when the strictures have occurred, they have some role in treatment of these strictures. And corticosteroids are only recommended in cases of airway edema. Antibiotics on a routine basis are not recommended, but it could be used in high grade or severe injuries, or if patients are on high dose corticosteroids, and drugs which cover our oral and intestinal flora are to be administered. So what is the role of endoscopy in corrosive ingestion? So the main purpose is to differentiate your high grade and the mild injuries to further guide your treatment and prognosticate the patients. So the clinical indicators or the lab parameters which could imply a severe injury are patients who have acidosis, hyperlactatemia, elevated TLC counts, or CRP, deranged LFTs. And if patients have free air under diaphragm in an X-ray abdomen, erect X-ray abdomen done, it could imply a perforation and probably go ahead with a surgical intervention in these patients. So the timing of upper GI endoscopy should be done early, within 24 to 48 hours, and avoided post 72 hours because of high risk of perforation. And management I will be discussing in the next slide. So the endoscopic classification of esophageal injury is the Zargar classification. So as discussed previously, we need to identify mild and severe forms to guide our further therapy. So this is a Zargar classification, classified from 0 to 3B. So 0, this is the normal mucosa. Grade 1, where there is edema and erythema of the mucosa. In grade 2, they have superficial localized ulcers with whitish membranes over the mucosa. In grade 2B, the ulcerations involve the circumferential mucosa. And grade 3A, there are focal areas of necrosis. And in grade 3, extensive area of necrosis involving the whole circumference. So in grade 1 and 2A injuries, just observation would suffice and early feeding, early initiation of feeding. And in Zargar 2B requires close monitoring, and Zargar 3A and 3B could probably require observation and also surgical interventions. So in patients where endoscopy is not possible, like patients are hemodynamically unstable, then go ahead with a CCT of the chest, airway, and the abdomen. So in grade A, this is the esophagus, which is a normal appearing esophagus and a normal stomach mucosa. But in grade B, where there is a thickening, a circumferential thickening of the esophageal wall and the gastric wall, and in grade C, where the post-contrast enhancement of the wall is lacking, and there is surrounding fat stranding and surrounding tissue involvement in grade C. So grade 3 is an indication to go ahead with emergency surgical intervention. So this is the algorithm for the management of patients with caustic ingestions. So it could be an acid or an alkali injury. Acid injuries, go ahead with an endoscopy and divide them based on the endoscopic findings as grade up to grade 2A and then 2B and the higher grades more than 3B. So how do we go ahead with the management? So all these patients have to be kept NBM initially, and patients with grade 0 and 2A, NBM overnight and trial of liquids when deemed appropriate. Grade 2B injuries to be kept NBM and consider early tube feeding or TPN if needed. And grade 3A and 3B injuries, patients should undergo a CT scan and urgent surgical consultation. Next, coming to the alkali injuries, could be unintentional or intentional. So in intentional, patients again undergo an endoscopy and classify the injuries based on the same Zargar classification. So here I would like to highlight, there were few studies that highlighted the USTA protocol, which means they tried patients who had grade 2B injuries. They tried to administer methylprednisolone for 3 days, a high dose, 1 gram per kg, and ranitidine, and also ceftriaxone. And they noticed the decreased progression of stricture formation or decreased incidence of stricture formation in these grade 2 injury patients. Next, what are the indications of emergency surgery in corrosive injuries? So in cases where you're suspecting a transmural necrosis on initial evaluation, go ahead with a surgical consultation and surgery. And the main objective is to remove all the necrotic tissue and prevent further sepsis. And you could either go ahead with a lab, a TIGLAB, or minimally invasive procedures. And the procedures that are done for these patients are either total gastrectomies, and it's advised to not do a partial gastrectomy because the process of necrosis and injury could be ongoing. And patients who are taken up for a surgical intervention, it's advisable to place a feeding jejunostomy in these patients to facilitate management of nutrition in these cases. So what are the long-term sequelae of corrosive ingestions? Could be major, like stricture formation, and it takes weeks to develop. And they could be managed either with endoscopic dilatations using a Pucci or balloon dilators, or go ahead with definitive surgery where the dilatation fails. And a longer time for surgery is supposed to be taken for the pharyngeal strictures, and a staged procedure is advised for these patients. So what are the surgical options that are advised for long-term management? If patients have strictures, they could go ahead with a colonic bypass. And patients who have a pharyngeal stricture, they undergo a staged reconstruction with myocutaneous flaps followed by a colonic bypass. And for gastric stricture patients, they go ahead with a Billroth gastrectomy, total gastrectomies. And minimally invasive surgeries could also be adopted in high volume centers based on the clinical expertise. Now, coming to the prevention of stricture formation, So corrosive injuries and the strictures are conditions that are very difficult to manage. So probably prevention is the key in these conditions. And early oral feeding may prevent the synechiae and the stricture formation in cases which have a superficial and a lower grade of injuries. And early rise tube placement in preferably endoscopic guided could facilitate your early enteral feeding and could also serve as a guide for later dilatation procedures. An early stent placement is a controversy whether to go ahead or not, because they say early stent placement could have a low success rate and chances of a high migration, cost implications, and not really recommended in the acute phases. And other pharmacological agents that have been suggested in prevention and treatment of these strictures are mitomycin C, which is an anti-cancer drug, which mainly halts or causes fibroblast apoptosis. So they have been shown to have a role in prevention of the stricture formation or even treatment, but studies have not shown a proven significant clinical benefit. Next, prevention of corrosive ingestion. So it is a public health impact. It causes both immediate and late complications and a major social and economic burden. So it's a completely preventable and an effective with effective public measures. So adoption of strict regulatory measures, laws are essential to reduce the incidence of corrosive ingestions. And developed countries show a decline with the effective enforcement of these regulatory laws. And strict regulatory actions are required in developing nations, like ban or regulate the sale of caustics in unlabeled containers, or restrict the open access to the corrosive substances, and mandate a child-proof packaging. And also important is community and family education, like parental awareness to keep away these corrosives away from the reach of children, and labeling and safe storage of the household chemicals. And psychosocial interventions, it's important to promote mental health awareness, stress management, and also counseling to prevent ingestions, because most of these ingestions are of suicidal intent. So these are the 10 tips to manage caustic ingestion in adult patients. So airway management first. As early, if you notice early signs of airway compromise like change in voice, stridor, go ahead and secure the airway early. Avoid harmful measures like activated charcoal or a vomiting or gastric lavage, or even insertion of a blind nasogastric tube. And no proven benefit of usage of milk or water as a dilution agent at home. Then identify the substance early and check for co-ingestions, because most of the cases will have co-ingestions, and suspect this if patients are hemodynamically unstable and who have altered sensorium, and refer these patients early to monitoring centers, ICUs, or surgical centers. Correct the systemic effects, and PPIs is also controversial, but it could be used to prevent further reflux related injuries, and steroids are better avoided in these patients routinely. And avoid endoscopy based decisions. They've mentioned that endoscopy overestimates these necrosis and sometimes could lead to unnecessary surgeries, and hence CT based assessments could be used for assessing the grade of injury. And perform early CT scans 6 hours post injury, and patients who have a grade 3 injury are referred for a surgical intervention. And bronchoscopy could be done before surgery to actually detect the transbronchial necrosis, the aspiration injury, and could further guide your thoracotomy or repairs related to that. And early rehabilitation and follow-up. Importance on psychiatric evaluation of these patients, and also importance of emphasis on the nutrition management of these patients. So this is a summary of what we saw in the previous two slides, the 10 steps to managing a corrosive injury patient. And to conclude, The extent of injury depends upon the type of the substance, the duration of the mucosal contact, and it's important to find out whether it's an acid or an alkali injury. And early GI endoscopy is recommended to identify the grade and to further manage the further treatment of these patients, and avoid endoscopy if patients are hemodynamically unstable or in cases of suspected perforation, patients who have severe respiratory distress and extensive oropharyngeal or laryngeal edema. Prefer CT scan in these patients. And ICU admission is suggested for patients with moderate to severe injuries for close monitoring and management. And emergency surgery is indicated for perforation, mediastinitis, and peritonitis. So prompt, appropriate, acute management improves the outcomes and reduces the long-term complications in these patients. These are my references. Thank you, sir.
Thank you, Kirtana. I think we have summarized the entire gamut of the issues pertaining to acid and alkali ingestion very succinctly, but with clear-cut policies and guidelines. Unfortunately, this kind of approach is not followed in emergency rooms, and most of these patients get a nasogastric tube. As soon as they come, they say some poison, and then they say later on there's acid, the tube is there. The commonest mistake we do is trying to get the tube out. If by mistake the nasogastric tube has been inserted in a patient with suspected corrosive or alkali ingestion, acid or alkali ingestion, the recommendation is to leave it in place, because if endoscopy is not possible, at least the nasogastric tube will act as some kind of a functional stent for the esophagus. But it is always better to avoid it, especially now the evidence for stomach wash and gastric lavage for other poisonings also is dwindling. Unless the patient comes within the first 1.5 hours, there is no advantage of doing a stomach wash for most poisons, most toxins in current day practice. So we need to think about it. As far as feeding is concerned, there is a little bit of doubt. When endoscopy cannot be done, we don't know the extent of injury, so it is better not to do percutaneous feeding accesses in these patients. It's always better to do a surgical feeding access post-pyloric in these patients. So that's another aspect. But otherwise, I think you have summarized everything that needs to know. Someone needs to know about corrosive poisoning. Ghanshyam, you want to add something?
See, I think the long-term morbidity in these patients is very high. Many people don't realize that, and it's not just the immediate management of what happens to a patient, but subsequently when the patient lands up with strictures, when the patient keeps coming for sequential dilatations or surgical interventions, the long-term morbidity in patients with severe corrosive injuries is very, very high. And to tide over the initial crisis, have a very, very high index of suspicion for esophageal perforation. Sometimes clinically it's very difficult to differ, kind of if it's a lower down stomach or the lower down perforations, many of, we are used to the typical signs and symptoms, but esophageal perforations can manifest with mediastinitis, which needs, repeating imaging. So we need to keep a very, very high index of suspicion for that. And nutrition takes a lot of importance because you may not be in a position to use the GI tract. So patients may have to be initially on the parenteral nutrition till you get a surgical feeding access. So these things are vital if we have to improve the long-term outcomes of patients with severe corrosive ingestion.
Thank you, Ghanshyam. I think it's not an innocuous substance. It has a lot of acute and long-term problems, and a proper understanding and an aggressive approach is probably needed to prevent more complications for these patients. Thank you, Kirtana. Thank you all for joining us today. And please do join us next week for another session on the Higgs platform. If you have any queries, comments, or suggestions on this topic, please do post them on the group from where you got the link from, and the moderator and the speaker will try to answer them at the earliest. Thank you very much, all of you. Have a good day. Bye-bye.
Thank you.
Thank you, sir.